Uh, Great to see you all here in this UP webinar and Up-Isar webinar. And today we are really fortunate to have our chief guest, none other than Padma Shri, Dr. Usha Sharma, Madam. Madam, it is really a great honor to have you here in this webinar. And you had always been our patron in this on this platform and at many other platforms. And you really made us all proud of your distinguished work in numerous capacities, in numerous organizations. And here I would like to say that despite so many achievements, you remain so simple and so much approachable, madam. And we know that just you are just a phone call away. Whenever we are in distress, we just call you and you give us some suggestion. And I would say a quote comes to my mind that the simplicity is the ultimate sophistication of character. So that suitably fits on your character, madam. So you are such a huge and a huge tree under which we are really thriving. So to name a few of many accomplishments of yours, and the list is endless actually. So she has been awarded Padma Shri by the President of India in 1985 and performed 600 11 surgeries in 24 hours. Awarded laparoscope by late Prime Minister Mrs. Indira Gandhi. Indira Gandhi Priyadarshini Award, Mahila Ratna Award, Meerut Ratna Award, Hari Om Ashram Alembic Research Award, Dr. B.C. Roy National Award, Mahila Jyoti Award, nominated
It's a
by
beautiful
Government
CV.
of India as an Minister for Health and Family Welfare, Rashtriya Ratna Award, Women of India Award, and
Yeah.
late Professor Dr. Kutti Lifetime Achievement Award, late Dr. S.N. Malhotra Award. Madam, list is really endless. And we know you very well, we all of us. So we would like to have your pearls of wisdom for all of us.
Thank you so much, Neelam, for telling such nice words about me. Am I audible?
Yes,
Yes,
madam.
ma'am. Yes, ma'am. Audible.
Okay. It's a matter of great pleasure that today I am with you all this evening on the occasion of webinar on induction of ovulation, which has been organized by UP chapter of ISAR, the president of which is Dr. Neela Mohri and secretary Dr. Latika Agrawal. Today's speaker is a very learned one. Dr. Jatin Shah is with us, and expert. I am very proud to say that expert is Dr. Sunil Jindal, who belongs to Meerut and is a very great. There is some sound coming from back.
Disturbance. Gaurav, you see some sound is there.
Some sound is
उसको
coming.
mute कर दीजिए. और
So
other
I
than
think that I'm really very proud that Dr. Sunil Jindal belongs to Meerut and he is a very, very renowned embryologist of Meerut. And then we have chairpersons, three beautiful ladies, I can say, who are very dedicated, hardworking, and are very competent. Dr. Rakhi Singh, Dr. Anu Agrawal, and Dr. I have not seen where is
Shivani
Sachdeva.
Sachdeva. Yes, ma'am.
Sachdeva
She's
has
there.
not. She's there.
Yeah, ma'am.
Okay,
She's one of the chairpersons. Yeah.
but she probably I didn't see her
She has
photo.
not joined, but she's one of the chairpersons.
Okay. So it's a great privilege that today we are going to organize a webinar on induction of ovulation. All of us know that whole probability of good pregnancy depends on the quality of the egg which is formed. With the increasing incidence of polycystic ovarian disease as well as primary ovarian failure, there is increased incidence of anovulation. And anovulation is almost accounting to about 20 to 30% of the infertility cases. And so it is very, very important for us that to know the details and the full knowledge of how to induce ovulation. We know that the induction of ovulation is very challenging and complex one. There are many agents today which are used for induction of ovulation, to start from clomiphene to letrozole to gonadotrophins and to GnRH releasing antagonist. These are the agents which can be used for ovulation. But certainly you have to have good knowledge and understanding which agent is to be used
Ma'am.
when. And so we have a very knowledgeable and a very experienced IVF specialist amongst us, Dr. Jatin Shah, who will be deliberating on induction of ovulation in IVF cycles as well as non-IVF cycles. And I'm sure that the deliberation today will go a long way in updating the knowledge of induction of ovulation, because this is a very, very challenging and complex, and we must know and we should actually understand it well. Then only we will be able to manage a patient well. I really congratulate Latika, you and Dr. Neelam Ori to organize this webinar, because this subject, though it is very, very common, but it needs to be
Very
discussed
complex
and
also.
learned again and again to have good treatment and management to your patient. With these words, I wish this program a great success, and thank you very much, Neelam and Latika, to make me a part of such a prestigious program. God bless you all.
Thank you so much, ma'am. Thank you
Thank you,
so much
madam.
for giving
Thank you,
your
madam,
valuable
for your
time.
kind words. Latika, 1 second. So we
Yeah.
know that today's webinar is really significant for all of us. And we have privilege of hosting Dr. Jatin Shah, a distinguished authority in IVF. Additionally, the topic of ovulation induction is of great relevance as it is an integral part of our daily clinical practice. So once again, welcome to all of you, the speaker, the most distinguished Dr. Jatin Shah, and all the uh, uh, chairpersons and all the attendees. And Dr. Latika, please
Yes.
carry on the meeting
Yes.
forward.
So, a very good evening to all of you present here. And this is Dr. Latika, UP-SAR Secretary. And I extend a very warm welcome to all of you present here on behalf of UP-SAR. So, today I am really privileged to be amongst all the dignitaries of international repute like Dr. Padma Shri, Professor Padma Shri Usha Sharma ma'am, and Dr. Jatin Shah. He's an eminent speaker. And thank you, Dr. Usha Sharma ma'am and Dr. Jatin Shah, for giving your valuable time and giving the consent today to present here in this webinar. So today's chairpersons are Dr. Jindal, Dr. Rakhi, Dr. Anu Agarwal, Dr. Shivani, as Madam have already told you. So we see in our day-to-day practice, whenever we treat any infertile couple, so ovulation induction is a challenging task. So we requested Dr. Jatisha to speak on IVF and non-IVF cycles, because some people they don't do IVF. So we want to increase the knowledge of all the degree, all the attendees, whether they are doing IVF or not. So now we request, I will request Dr. Rakhi. She has joined. Dr.
Rakhi?
Gaurav, please show me the resume of Dr. Rakhi. Dr. Rakhi's resume.
Okay, ma'am.
Dr.
Mr.
Rakhi
Ankit,
Singh.
please show the resume of Mr. Rafiq.
Mr.
Dr.
Dr.
Rakhi.
Rafiq. Sorry.
And Dr. Rakhi is she is the president of Noida Society, and she is the governing council member of ICOG 2024-25. She is the vice chairperson of UP State ISAR and peer reviewer of Journal of Obstetrics and Gynecology of India and chairperson of Endocrinology Committee. And awards achievements, she is invited faculty for 380 national and international conferences, convener of FOXY ICOG GCPR. She is the editor FOXY Foxy DC Datta Award for Publication 64 AICOG 2022 and Foxy CS Dawn First Prize at 65 ACOG 2023. So it is a wonderful CV. Dr. Raki, welcome you as a chairperson. And show me the resume of Dr. Anu Agarwal. Gaurav.
Next,
Can you click
Next,
on
please.
my fifth resume? Make a PowerPoint mode and
Dr. Anu, she's from Varanasi. She's MD Obstetrics and Gynecology, FIAMS Director, Vansh Fertility and Test Tube Baby Center, Aishman Hospital and Taruna Trauma Center, Aishman Multi-Specialty Hospital Private Limited, Executive Committee Member ISAR. She's the Joint Secretary VOGS, and her field of interest are minimal invasive fertility enhancing surgery, ART, and presented various papers in national international conferences. Welcome, Dr. Anu Agarwal, the chairperson today's webinar. And the next chairperson, Dr. Jindal. Dr. Jindal, he's a known andrologist. She's the consultant andrologist and scientific director of Jindal Hospital and Fertility Center, founder Freedom from Infertility Society, gold medal for best postgraduate MAMC New Delhi, and 35 awards from different organizations Dr. Jindal has got. And many publications and presentations. He has got chapters in 24 textbooks in fertility. Welcome, Dr. Jindal, in today's webinar. And Dr. Shivani Sachdeva. Gaurav, show me the resume of Dr. Shivani. Dr. Shivani, she is MD, DNB, MR, COG from UK, Director, SCI IVF Hospital, and Clinical Research Fellow, Imperial College and Hammersmith Hospital, and featured in Limca Book of Records. She's the founder secretary of Delhi chapter of ISAR. So welcome all the chairperson. Now hand over the session to the chairperson, Dr. Rakhi. You can read the resume of Dr. Jatin Shah, please.
can we have the resume of Dr. Jatin Shah? As we all know, Dr. Jatin Shah is a star-studded faculty for us in India, and who would not want to listen to him other than any of the gynecologists or anybody? And
Gaurav, Dr. Jatin Shah, next one.
next one.
Last one. Huh? So I can read. Dr. Jatin is MD DGO, and he successfully established pregnancy in more than 17,000 infertile couples since 1994. In 1995, he won first prize in Best Paper Presentation for the topic IVF and Tubal Factor Infertility, Foxy Conference in Jaipur. And in 2003, he was awarded as Young Personality of the Year by the governor amongst the outstanding young Indian JCs. He has been associated as a guest speaker, faculty panelist, guest orator in more than 300 national and international conferences. And he's a founder member of Aspire and having numerous presentation and publication national and international. He is extremely well versed with IVF, ICSI, IUI, oocyte donation, sperm donation, embryo donation, and surrogacy. Currently performs close to 200 cycles of IVF ICSI per year within an average of 18 to 100 IVF pregnancies every month. A wonderful CV, Dr. Jatin. He has conducted largest study on the use of GCSF in patients with repeated implantation failure, thin endometrium, published International Journal of Infertility and Fetal Medicine 2014, and published association between progesterone elevation on the day of human chorionic gonadotropin trigger and pregnancy outcomes after fresh embryo transfer in IVF cycles. A review, Frontiers in Endocrinology section, Reproduction 2017. And IVF for tubal factor infertility, Dr. Jatin, Dr. T.C. Anand Kumar, Dr. Indra Ahuja, 1988. And published preterm birth among pregnancy conceived by ART in Mumbai. Original research article in the International Journal of Reproduction, Contraception, Obstetric and Gynecology, April 2018. And chapters on ovarian stimulation protocols, embryo vitrification, embryo transfer techniques in textbook, practical IVF tips and techniques 2014. So, Dr. Jatin, we welcome you on this webinar and thank you so much for giving your consent to come this webinar and talk on ovulation induction, all about ovulation induction. We are really eager to hear you. Please, you can start your talk now. Stage is all yours.
Thank you so much, Latika. Respected Dr. Usha, it's indeed an honor to be speaking in your presence. dearest chairpersons and all the office bearers, Dr. Neelam, Dr. Nilima, Dr. Anu, Dr. Rakhi, of course, my dearest friends, Shivani, Sunilji, it's all a pleasure to be a part of this wonderful UP chapter of the ISAR. And today I'm going to take you through a very simple journey starting from absolutely basic ovarian stimulation for the simplest of our patients of intrauterine insemination for all those who are still at the level 1 ART clinic. And then I will take you on to something more advanced. And at the end, something that we all might be doing on a day-to-day basis in a couple of years from now, especially when it comes to triggering and monitoring and stimulating our very difficult patients and very difficult cases of poor response and high response. So to begin, of course, with the simple basic facts, we need to remember that first of all, you need to be careful of the law. If you are going to be doing IUI or handling gametes, even in an IUI, you need to have a ART level 1 registration. On the other hand, of course, we all know that ART level 2 clinics can perform all the IVF procedures. So for simple OI and timed intercourse, you do not need any registration, but for IUI, you need to register as level 1 clinic. If you are stimulating a patient and sending her for egg retrieval and IVF to another ART level 2 clinic, you need to make sure that your patient has undergone a complete counseling from the level 2 clinic at least once, and that all drug prescriptions are issued by the level 2 clinic itself. So this is very important small points, but if you don't comply, you could fall into trouble. So let us first begin with intrauterine insemination. And here we know that our aim is not to get 15, 20, 30 oocytes. We just want 1 or 2, maximum 3 good quality follicles and eggs. We want to keep it nice and cost effective and simple. You want a good endometrium. You want to do a good timing of the IUI. If you're using gonadotropins, you do not want a premature LH surge, and you want an optimal pregnancy rate. Of course, it's too much to ask, but if you go about it scientifically, it's pretty simple to achieve. So first you need to know that which category of responder does your patient belong to. And to help you do this, you have to take into account the age, the AMH, the AFC, the BMI, whether she has associated PCO or endometriosis. But the most important in this list is what has been her previous response in a previous cycle, whether you did it or some other clinic did it, and how she has responded to ovulation induction with letrozole, clomiphene, gonadotropins, and so on. So is there a best protocol for IUI? And today I'm going to give you only that one practical protocol which I follow for most of my IUI patients, especially the PCO or the anovulatory category, which is of course 50% of your IUI practice anyways, and which also works wonderfully well for our category of unexplained infertility. So we know that for IUI, these are the two main indications. Male factor doesn't seem to do too well, especially severe male factor infertility with IUIs. So we shall give you a protocol which will work really well for anovulatory PCO patients as well as those with unexplained infertility. So the most simplest and the best protocol, of course, we have to take into consideration lifestyle management, weight loss, and so on for a high BMI PCO patient. Letrozole 2.5 BID alone was recommended in the past. Then we also use clomiphene. Then we found out that letrozole is better than clomiphene. But the second protocol in this slide, the sequential letrozole HMG protocol, is the one which is a personal favorite and which to my mind gives the best outcome for IUI pregnancy rates in PCO patients. And finally, we'll end up with a little bit of the chronic low dose step up, again, making it simple and not as elaborate and complicated as you read about it in the text. So what is this sequential protocol? Basically, you will give letrozole 2.5 BD from day 3 to day 7. Very important to follow the days. You then call her in on day 8 or day 9 for a follicle study. The minute you see 1 or maximum 2 leading follicles in the range of 14 millimeters is the day you will begin 75 IU of HMG if she is a thin patient, or 150 if she is a high BMI patient. At the same time, you will also start administering cetrorelix along with the HMG until the morning of HCG. Now, suppose today is a Thursday and I find that her follicle today morning is 18, 19 or 20 millimeters. Today is the day I would like to trigger. So normally I would give the last cetrorelix today morning. I would then give an HCG trigger, usually just 250 of recombinant HCG is enough. Since we begin our mornings very early at our clinic, I would like to administer the trigger at 3 p.m. today afternoon, knowing that she is going to rupture at 40 to 42 hours post HCG like clockwork. And because I have given her an antagonist, she will not have any premature LH surge or LUF or unruptured follicle. And when they come in on Saturday morning at 8, 8:30, she would have just had a fresh rupture. And at that time, you take the husband semen sample, process it, wash it on your gradients, and do a single IUI around 42 hours post the HCG trigger. And as shown by Porley in 2017, you can clearly see the sequential letrozole HMG protocol will double your clinical pregnancy rate as compared to clomiphene HMG from 12.6 to 26.51%. What happens if she does not ovulate or a dominant follicle doesn't pop up after a 5-day regimen of 5 milligrams? You could extend it to 7-day regimen in the first cycle. And if yet you do not manage to get an ovulation, you could step up to a 10-day regimen as well. But of course, if the patient has already undergone these treatments before landing up at an infertility clinic, again, addition of HMG makes more sense than extended letrozole protocol. But of course, for those who are still at the stage where you don't want to use gonadotropins, you can see when you do this, you can see your failure to ovulate with 5 mg. You give a 7-day regimen, you will have some responders and some pregnancies. Those who don't respond, you then do the 10-day regimen. Again, you will have non-responders and you will have responders and again have some pregnancies. So with this, you can expect a cumulative live birth rate of almost 25%. But this is the problem with the 10-day regimen, that you have a slightly higher miscarriage rate because of excessive suppression of estradiol levels, obviously with aromatase inhibition. And therefore, you have a higher miscarriage rate at 18% as compared to just 5% with the 7-day regimen. Of course, why do we recommend a sequential protocol and not just clomiphene or not just letrozole? Because we know with clomiphene that although you get ovulation in 80% of patients, you get pregnancy in just about 35 or 40%, and you will have 1/4 of these patients who will not respond and will be CC resistant. And even in those who ovulate, you most often don't get pregnancy because of the anti-estrogenic effects of clomiphene on the endometrium and the cervical mucus. Letrozole, of course, it came like a magic wand, but again, remember that you do get higher rates of ovulation and better live birth rates than clomiphene, but yet there are 30 or 40% of patients who will not respond to aromatase inhibitors as well. And that is where gonadotropins come in, because gonadotropins almost always 100% will induce ovulation, even in the most severe of CC resistant cases. Of course, it's not a guaranteed monofollicular development. You might have to counsel her for cycle cancellation, or best is to counsel her for a conversion to IVF, so that you don't end up with wasting the money on the gonadotropins or inviting the anger and wrath of the infertile couple. So, of course, we have to move on to gonadotropins as well. Although American guidelines for unexplained infertility say gonadotropins should not be used and so on and so forth, in India, we have patients who are on an average 5 to 10 years younger than the West, and there is always place for 1 or 2 cycles of gonadotropin IUIs as well. To play safe, especially in the anovulatory group, you need to do the chronic low-dose step-up protocol. And initially, there was criticism, oh, the follicular phase is too long, there are too many needles, it goes on for 30 days and so on. But what is the actual truth? And Homburg and Howells in 2014 clearly showed that with the chronic low-dose step-up, you have monofollicular development in 70% of patients, pregnancy rates of 40%, multiple pregnancy rate as low as just 5.7%, and an extraordinarily low prevalence of OHSS. And the best part is that the 90% of patients on a chronic low dose protocol develop the single large follicle meeting HCG criteria within 2 weeks or 16 days without any change required in the initial dose. So contrary to our belief that, oh, it goes on for 25, 30, 35 days, it actually doesn't. Of course, you don't need to start with 37.5. You should start with 50 or 75, and you are likely to get a good outcome without your risks of hyperstimulation or very high order multiple pregnancies. This was another paper which corroborated the same fact. You can see he started with a high dose of 112.5 per day, increased by 37.5 every 2 days, and then gave rec HCG. And again, 40% incidence of monofollicular cycles, 30% clinical pregnancy rate, 0 multiple pregnancies, and mild OHSS in just 3 out of almost 30 patients. So those of you who are beginners, please use nomograms. These are easily available on the PubMed. You just have to plot the antral follicle count versus the weight of the patient on a simple graph. For example, you have a patient weighing 65 kg with an antral follicle count of 15, and the nomogram clearly shows you that the starting dose should not be 100 or 50, but it should be a good in between 75 IU. So this is how you begin using your gonadotropins and not worrying too much. If you follow simple basic guidelines, you will not end up with any complications. The arguments against gonadotropins always are, oh, there will be a lot of twins and triplets and so on. But you need to just keep these things in mind. Don't start with a very high dose. Have strict cancellation criteria or tie up with a local level 2 clinic, so that if you see more than 3 or 4 or 5 follicles, you have already counseled the patient that I will convert you to an IVF, because this is the lowest dose I can give you. And there is no guarantee that in the future you are going to respond with a lower number of follicles with a lower dose. So just convert her to an IVF and expect an excellent outcome. Use sequential letrozole HMG protocol. Again, I repeat, because the dominant follicle, 1 or 2 max, are selected by the letrozole, and the HMG only helps to improve estradiol levels, to prevent LUF, to give you perfect precision timing and control on HCG and the timing of IUI. So if you follow this approach, you are likely to have very good pregnancy rates with your IUI program. Of course, you have to prevent the premature LH surge whenever you are using gonadotropins, whether it's a sequential protocol or a gonadotropin protocol alone. Please add the antagonist. The antagonist is extremely cost effective, very not too expensive in our country, fortunately for us, because as you remember from this study from Berlin 25 years ago, that when you use gonadotropins without a GnRH analog, 1 in 4 patients will have a premature LH surge, and it doesn't justify not giving the antagonist. When we are as it is struggling at a 15 to 20% chance of pregnancy in an IUI cycle, to make them spend on the gonadotropins and then lose 1 in 4, even having a chance of a pregnancy just because you omitted the antagonist, is absolutely not fair to the patient. So it will help you to control the surge. It will help you synchronize to a single IUI. You don't have to worry about doing an IUI one day before or one day after ovulation. And you can also play with it by a day or so that you can postpone a Sunday IUI to a Monday without an adverse outcome if you have used the antagonist. So you can clearly see here numerous studies, but I'm just showing this one. When you add the antagonist in an IUI program, premature luteinization is almost completely eliminated, and pregnancy rates are up from 15 to 25% per cycle. Another common area of confusion is when to trigger and when to time to do a single or a double. Very, very simple. I already explained it to you before. All you need to do is just remember basic physiology. The triggering size in letrozole HMG should be around 90 to 20 mm. In CC cycles, you could do it at 21 or 22. In pure gonadotropin cycles, try to trigger at 17 to 19. So that is first the diameter at which triggering is ideal. Remember, ovulation will normally occur at 40 to 42 hours post HCG, which is why in IVF we do egg retrievals at 36 hours post HCG. But the main point is that once you have processed a semen sample and the sperms are activated and capacitated, they can only fertilize oocytes for 2 to 3 hours post preparation time. So if you do an IUI one day before ovulation, there is absolutely no scientific basis to that IUI, and it's a sheer waste of time, money, and energy, because those sperms are not going to be around in a fertilizable manner when she ovulates the day after. On the other hand, if you are worried that what if she ruptures before 40 hours, remember that oocytes are fertilizable for 12 to 16 hours post ovulation. And this is the important key point, that why you need to inseminate post ovulation. You may feel that, oh, what if she ruptures at 8 a.m. and I do a IUI at 12 noon? You have not lost nothing. You are still well within the 12 to 16 hour post release time, during which you will still get excellent pregnancy rates. So again, numerous papers clearly showing that 42 hours is when you expect the highest clinical pregnancy rate, as you can see in this study at 38%, as compared to doing it too early or too late. So simple physiology, use of the antagonist, triggering as per your laboratory opening and shutting times, and you will be back on track with an excellent IUI pregnancy rate. So just to summarize, for IUI gonadotropins, we know for poor responders, you would like to give them coenzyme Q, whether you're a believer of DHE or testosterone, maybe in the month or two before the IUI. If you're using gonadotropins alone, say a patient has an AMH of 0.5 and she's 39, you could even use a starting dose of 150 or even 225, because she is not a candidate to hyperstimulate. And again, always add the antagonist. Normal responder, starting dose of 75 to 150, go step down by a little bit and use the antagonist. This is, of course, if your letrozole and letrozole HMG cycles have failed, then I'm talking about the third cycle where you want to use only gonadotropins. And the third, high responder, stick to a low dose step up protocol, use a nomogram, always counsel for cancellation or conversion to IVF whenever you are using a gonadotropin alone protocol for a patient of PCO. And don't be too scared of hyperstimulation and multiple pregnancies, as I showed you with the astute deciding of doses, monitoring, using a low dose step up, you are unlikely to have a very high incidence of OHSS and multiple pregnancies. Of course, moving on to the main part, and that is controlled ovarian stimulation for IVF. Where are we today in 2025? We know that we want a very simple and safe ovarian stimulation protocol. We want it to be efficacious, a very high cumulative pregnancy rate. But the actual goal is not to get just the 5 to 15 oocytes as shown in Sankara's original classic study when we were talking only of fresh embryo transfers. So that was 15 years ago, before the days of vitrification, when we knew that the best pregnancy rates in fresh transfers were if you got between 5 to 15 oocytes. Anything more than 15 would result in supraphysiologic estradiol levels, very high premature progesterone rise, and therefore adverse effects on endometrial receptivity, and the pregnancy rates used to drop. But today we are not worried about that. We want to make sure we get the maximum number of oocytes in the first cycle. So we are aiming at 15, 20, 25 oocytes. We want to have enough top quality embryos for freezing so that you have a high cumulative live birth rate, ensuring not only that the patient has a first offspring, but even a second offspring from the same one ovarian stimulation. Sounds like a dream, but it can be true for almost 70 to 80% of your first cycle normal responder patients, and even a lot of your PCO patients and some poor responder patients. So when you get a normal responder, your first aim should be that you do not want to convert her into a Poseidon 1 and 2. And what is Poseidon 1 and 2? We know Poseidon 1 and 2 are young and old patients who came to you with a normal ovarian reserve, beautiful antral follicle count, excellent AMH levels, young, under the age of 34, normal BMI, and you thought, yes, with 150 IU, I will get 20 oocytes, and yet you give her 225 and you just end up with 4 or 5 oocytes. So this happens so commonly, and there are so many avoidable reasons for not having such an adverse outcome. Of course, for the expected Poseidon 3 and 4, there's not much we can really do as a pre-planning, but you can definitely focus more on your normal responders to make sure that you don't iatrogenically create a Poseidon 1 and 2 in your practice. Again, to categorize the response, the same factors come into play. That is she going to be a poor or a normal or a high responder? But just to take individually, remember that AMH is a good marker of oocyte quantity, but does not reflect oocyte health. So when you compare a same AMH level, Poseidon 3 and 4, a 30-year-old and a 40-year-old, you know that the oocyte quality is not going to be the same. And remember that age is still the strongest driver for determining your final success rate, irrespective of however many add-ons you give to the patient, such as blastocyst or PGT or ERA. You cannot counter the detrimental effects of advanced maternal age. So AMH, of course, many a times I find that on ultrasound, she looks like a PCO and the AMH is showing 1.8 or 2. And the minute you take a history, she says, yeah, I was put on Femilon or Novelon or something for the past 2 months to regularize my menses. So remember, OC pill use will give you an artificially lowered AMH level. Current smoking and low vitamin D levels are the really known and proven factors for an unexplained decrease in serum AMH at a young age. And that is important points clinically to remember whenever you are interpreting an AMH level. Antral follicle count, we do it so simplistically and we just quickly sweep from one ovary to the other and say, okay, AFC is 4 to 6, but look out for the very small follicles. And this wonderful paper from 2024 by LVG shows that what makes a normal responder a Poseidon 1, where you get less than 9 oocytes, 1A less than 5 oocytes, it is because you missed the number of smaller follicles, especially those in the range of 2 to 5 millimeters. So potential normal responders with very few small antral follicles are the group which are likely to end up being Poseidon 1s, rather than those where you see a lot of small antral follicles. So again, little bit of fine tuning. give it a little more extra attention so that you know, okay, she has very few small follicles. I need to give her a higher dose of FSH or maybe add some LH from the beginning and not get a Poseidon 1. The other important factor, again, if you have a patient who has done a previous IVF cycle anywhere in the world, do a detailed examination of that cycle. Because even more important than AFC and AMH, it is her response in the previous cycle, which is the most important predictor of what should be your starting dose of FSH HMG in your cycle, and also which protocol you should be using, whether you should be using a PPOS or an antagonist or an agonist or a dual stim or a term stim. Everything depends on your study of her previous response in the IVF that she has undergone before coming to your clinic. So I still find a lot of places, they still give just 150 IU of FSH to a normal responder, thinking they will get their 20 oocytes, and then they end up with just 3 or 4 metaphase 2 oocytes. Wonderful study from Padma Rekha and Fadi Sharara 2022, especially wonderful because it was done on Indian patients, clearly showing that for predicted normal responders, you will have more oocytes with 200 or 225 compared with 100 to 150. At the same time, this doesn't mean that you give 450 to everybody, because we don't want increased cost of treatment. And we also know that very high FSH may not be very conducive to good outcome and good number of metaphase 2s. And this is an important concept I'm going to show you here today towards the end, when I describe what is called term stimulation. Just like we have a full term pregnancy of 9 months, we now have a new concept called term stimulation, which will come to shortly, which clearly shows that excessive FSH is not to be given if you want a good outcome. So look at all the factors that determine or predict that how many metaphase 2 oocytes you are going to get. Of course, we have AMH, AFC right at the top of the list. And again, to drive home the point, as the study showed, that 150 and then continuing 150 from day 7 gave you significantly lower counts of retrieved M2 oocytes compared to all the other higher doses that were administered. Again, remember that higher starting doses are not necessarily going to give you better outcomes. Somebody needs to mute, please. And in the future, we know that AI models will help us to calculate with proper algorithms the exact starting dose so that we avoid unnecessary increases in medication and improve treatment cost efficiency. And the first trial using AI to give us an algorithm for personalizing as per the patient the starting dose, which we take so casually, and we always think it doesn't really matter whether I give 200 or 225 or 300 or 450, but it does, and it will help us to really personalize, individualize, and get much better outcomes for our patients. Always be wary of polymorphisms. And how do you know? Of course, we can do the test. It's not very expensive. It's easily available. But remember, what are these polymorphisms? Many a times you expected that the patient would have a good response, but she ends up being a Poseidon 1 and 2. Besides the low starting dose, the second most important contributory factor is the presence of polymorphisms. And then you have your hypo-responders. You know, there are patients who have stagnant size follicles from day 6 or day 7. You feel, oh, she's already on day 10, and still you just have follicles in the range of 12 millimeters, whatever I do. So these are again likely patients carrying not only polymorphisms of the FSH receptors, but also of the beta variant of the LH receptor. So it doesn't mean that you just step up FSH doses. These are patients who need LH right from day 1. Addition from day 7 is still too late. So if she has a previous cycle where a follicular phase of stimulation went on for 20 days, you know you need to add LH right from the beginning for these patients. So what, just a little bit theoretical knowledge here, that patients who are homozygous for the serine, they require more gonadotropins, they have longer stimulation, higher basal FSH and lower estradiol levels. And normal and patients with a variant of the beta subunit of the LH gene also need higher dose of stimulation, and other ones who are likely to be hyporesponders with stagnant sized follicles. So you can see here in this study, abnormal responders, significant prevalence of serine at position 680 of the FSH receptor. Normal responders, majority of the patients were homozygous for aspergine at position 680 of the FSH receptor. How do these go about in normal life? Means we have so many women, I'm sure, who with polymorphisms do get pregnant normally and naturally without resort to IVF. And a wonderful study here from 2018 showing that polymorphisms even affect the normal natural population. So here you can see they had 21 to 34 age group, almost 300 consecutive women conceived naturally. And these are the ones who had or didn't have polymorphisms. And they found that women carrying the SER polymorphism had a significantly longer time to pregnancy compared to the other normal variant combinations. So this again is more evidence that you have to be wary of the polymorphisms of our FSH receptor. The next important step for really getting a fantastic outcome from your stimulation, ensuring a 90% conversion of metaphase 2s, is to have a uniform synchronous cohort. And we can't just emphasize this enough. And now enough of the Poseidons 1, 2, 3, 4, because which only takes into consideration age, AFC, AMH, and number of oocytes which were retrieved. But is a poor responder only about these numbers? We need to understand what category of poor response is your patient in. And we now have new insights into the physiology of poor response, categorizing them further into a poor responder who is well compensated, a poor responder who is in the stage of desynchronized cycles, a poor responder who is in a stage of pathological premature LH surges, and you have the very severe ones with a stage of completely suppressed follicle growth. And what is the importance of these? So the compensated stage is the one who comes to you with a low MH, high FSH on day 2, normal E2. Normal E2 on day 2 is the clue that she is well compensated, that a follicle was not recruited in the luteal phase of the previous cycle. Development of a mature follicle more than 18. So she's going to go to 18, 19, 20 like normal people and not rupture at a early smaller size. And again, another important clue, she will have a normal cycle length of more than 26 days. Now, all these things have been in your minds. You have seen that patient, despite your best effort on starting early morning day 2, on day 7, one follicle is 16 mm, the others are smaller. This is because she was not well compensated and she is in the next phase of a desynchronized cycle. And you've also seen many a times that a patient, you gave antagonist the minute she became 14 millimeters and you called her after 2 days and the follicle was gone. So she ruptured at 16 or 17 and did not reach 18 or 20. And that will be the third stage, which I'll come to you shortly. So how do you recognize that she is a desynchronized cycle stage poor responder? Low AMH, normal FSH, high estradiol on day 2. And this is again the clue that her follicular phase started in the late luteal phase. The follicle has already been initiated. Estradiol secretion has started, which is why the FSH normalized. She will have a mature follicle, but because she started her follicle development in the late luteal phase, she will have a shorter cycle length. So she will have a short follicular phase, she will have a short cycle length, and she is the one classically who, if you do not give her any pre-treatment, will definitely have one dominant follicle and a totally asynchronous cohort. The third stage, again, very important. All of you have seen this, but never one realized why it happened. The first knee-jerk reaction is to call the company which gave you the cetrorelix and say, this batch is not good, please take it away. But remember, she is the patient who is prone to pathological premature LH rises even before your lead follicle is 14 mm. So low AMH, high FSH, normally to short cycle length and premature rupture of the follicle is the classic case of this particular stage, where again you need to pay more attention to make sure that you do not have a rupture before you can pick up the oocytes. And many a times you have empty follicle syndromes also, because the antagonist just managed to stop the rupture of the follicles, but the luteinization happened, and therefore when you tried to pick up the oocytes, you just had clear empty fluids. And of course, finally, you have your very, very bad cases, almost like flogging a dead horse, very low AMH, very high FSHs. They are almost premature menopause or ovarian failure, very low E2 levels, just don't respond, don't produce any follicles, and may often have gone into a premenopausal picture of menstruating every 2 or 3 months and may not even be menstruating without an estrogen progesterone challenge. So that brings us again to pre-treatment, that how do you treat these various categories of the poor responder? So of course, luteal estradiol valerate, if you begin from day 25 of the previous cycle, might prevent the dominant follicle from being selected if she is in stage 2, and you continue this during menses until you begin your FSH. Second, norethistérone again would be equally effective antagonist days 2, 3, and 4 may not be very effective for this category because the follicle was already selected. And of course, you have your short 10 to 12-day course of oral contraceptive pills. So these are the 4 methods that you can use for antagonist cycles and hope that you get away without a dominant follicle being selected. Although, again, these pre-treatments may not prevent premature pathologic LH rises. Now, all of you wonder that why this OC pill argument keeps going to and fro. Remember that you can use OC pills, although I have been a strong advocate against, because you have to remember one thing. All ART clinics in the US, they use OC pill pre-treatments to avoid weekend work. But if you look at their protocols, they always use a combination of REC-FSH and HPHMG right from the beginning of stimulation. And that is the key. So besides the 5-day pill-free interval, you can also have a 7-day pill-free interval like a lot of Chinese clinics do. And when you begin stimulation, always add LH right from the beginning. Then you will not see any adverse effects of the OC pre-treatment. But if you give the OC pill pre-treatment, have just 3 to 4 days of washout, then start just with a pure FSH protocol, you will have a very slow response, a very prolonged follicular phase, because you have suppressed the LH so much that you will just not have enough of follicular activity and growth of the follicle as you would like to have. So always balance any new paper that you see as to which country it's originating from. If they used OC pill without any adverse consequences, what was their stimulation like? And you will see that they begin always with a combination of FSH and HMG. The next, of course, and my personal favorite is the long agonist protocol. So if you just don't want to go into stages 1, 2, 3, 4 and take care of all of them in the simplest possible manner, just use our classical gold standard long agonist protocol. So when you do a mid-luteal start on day 21, you make sure that no dominant follicle is recruited. There is no endogenous FSH in the late luteal phase to recruit that follicle. You will not have any premature pathologic LH surges or luteinization or ruptures of follicles because you have completely physiologically and scientifically taken care of those two issues. Plus, because in this downregulation suppression program, we know that no follicle will get recruited till you don't begin exogenous FSH. You will have a perfectly synchronous cohort of follicles. And those of you who started practice like me 30, 25 years ago will remember that we never heard the term follicular synchrony because we always had synchronous follicles. We only had the long agonist protocol, and we almost always only used HMG rather than REC-FSH in those times. So again, the trick, just like the OC pill protocols, is that if you use a long agonist protocol, you must begin with a combination of FSH and LH or even HMG alone to make sure that you get a perfect follicular cycle. And even if you have just 3 oocytes, you hope to get at least 3 metaphase 2s and maybe 2 top quality embryos to give your patient a better outcome. So this was Lembach study in 2017, clearly showed pregnancy rates in fresh transfers lower with antagonist. The agonist protocol gave more oocytes, and ongoing pregnancy rates were lower when you used a flexible antagonist protocol and OC pill pre-treatment. Another recent study, 2019, again in fresh cycles, you can see agonist giving you higher number of oocytes, higher number of 2PN zygotes, more embryos, higher clinical pregnancy rates, 32 goes up to 58%, and almost a doubling of the live birth rate. And this is purely because you have successfully treated stages 2 and 3 of the poor responder, and you have prevented any adverse outcome even in your normal responders who are not in the Poseidons 1, 2, 3, 4. But the final proof has come with this study in 2024, where the first cycle of a patient, they divided into 2 groups, first agonist or a first antagonist. So all the 437 patients were on their first IVF cycle, and they wanted to see what was the difference between the 2 protocols. Of course, they did not take any PCO patients in this. Clearly, you can see, as the yellow bar shows, higher number of oocytes with the agonist as compared to the antagonist. Not really a big surprise there, but ongoing pregnancies and live births 7% higher in the agonist versus antagonist. So although it did not reach statistical significance, to my mind, if a 35% becomes a 42%, it is always significant. And even if I get a few extra pregnancies with no extra efforts, it would definitely be worth its while. So there is a strong case now for rejuvenation of the agonist protocol for a lot of our patients. Then you would argue that how can pregnancy rates be lower with the antagonists? So remember, LH surges occur in over 8% of fixed start antagonist cycles. That means even if you start at 14 mm, you 8% of your patients can still have micro LH surges compared to almost 0% with the agonist. 80% of these surges occur before you give your first antagonist. So if you have a fixed day start, like a lot of clinics do on day 6 of gonadotropin, irrespective of follicular size, you are yet likely to be late in starting the suppressive effect. Asynchronous development, especially if you have started off an antagonist cycle without any kind of pre-treatment, will result in asynchrony, and that again will reduce your pregnancy rates because you have lower top quality embryo percentage which is finally received. And also we know that when you do an agonist treatment and you completely suppress endogenous FSH LH, you don't have any large forerunner dominant follicles, and the more higher synchrony that you have, the better the number of M2s. But really what is important is that the agonist also gives you a superior endometrium. So they have found that with the antagonist, there is a significantly lower Hoxa-10 expression in the endometrial stroma cells, which impairs endometrial receptivity for fresh transfer in an antagonist treatment cycle. So these are very important. These are all established public scientific research, and we need to pay attention to all this now if you are to take your success rates up from your 40% over the last 2 decades to say about 45 or 48% every month and every year without fail. What about PPOS compared to the long agonist? We know in the long agonist, the criticism is that you need to give a lot of exogenous gonadotropin because you have cut off endogenous gonadotropin totally. And yes, that's true. So you have the option of doing PPOS if she is anyway for a frozen transfer and you're not contemplating a fresh transfer. PPOS has a similar effect, although I still wonder how it will ensure synchrony. But as the studies show that you have significantly similar number of oocytes, and pregnancy rates also seem to be similar to the agonist long protocol group. Of course, it's just one publication, so I'm not going to have a knee-jerk switch from my long gold standard long agonist protocol, but it's an interesting area because we can eliminate about 25 needles if we could switch from the agonist to a PPOS protocol for some of our patients. So of course, we know the secretion of pituitary gonadotropin is not as strongly inhibited with PPOS as compared to the agonist, and which is why your gonadotropin dose would be lower than with the long agonist protocol. LH supplementation, again, we've gone to and fro, to and fro, to and fro. 30 years ago, we had only buserlin for down regulation. We had only one FSH called metrodin from Serono in those times, which was pure FSH. And we had Pergonal, which was a combination of 75 IU FSH and 75 IU LH, which was the HMG available to us. And at that time, we had two standard protocols. Young patient, normal ovarian reserve, you have to give M2P1, means two metrodins and one pergonal. That means 225 FSH and 75 LH. That's the 3:1 ratio. And if she's a poor responder, potential poor responder, or a woman above the age of 35, we used to give M3P2, which meant 375 of FSH and 150 of LH. So this then over the years with a lot of research things came, oh, you should not give LH, you should not use HMG, you should use pure FSH, then you should use highly purified FSH, then you should use REC FSH, then you should use long acting REC FSH, then again HPHMG came in as an addition, REC LH came in as an addition, and now we have commercially available preparations again giving us the same 2:1, 3:1 combinations of FSH and LH. So it's gone a complete circle. Luckily, clinics which believed that do not make changes suddenly always gave LH from the beginning and continued to do so like we did at our clinic. Some clinics tried to switch to complete REC FSH cycles, and then they found that the results were not as good as they used to get before. So all women above the age of 35, please give LH right from the beginning. 150 is minimum, not 75. Hypo responders, again 75 to 150 right from day one if she's had a very slow response in the past. Patients with hypogonadotropic hypogonadism will need a starting dose of 225 to 300 of FSH and LH. You cannot give FSH to these patients. You do not have to give them any antagonist or agonist. You cannot use an agonist trigger because she doesn't have any hypophyseal pituitary function. You have to use the HCG trigger, but they have excellent success rates because their egg quality is fantastic. And of course, you need LH for all the Poseidon groups. The next important factor for ensuring a good retrieval of metaphase 2s as compared to the number of follicles that you had is the trigger that you use. And remember, a lot of us feel that the HCG trigger is the best because it's the strongest, because it gives us hyperstimulation and so on. It has a long half-life. But is that what happens in normal physiology? So if you go back to Spiroff and look at the normal menstrual cycle, you don't have only a mid-cycle LH peak, you also have an FSH surge. So it is this combination of FSH and LH surging at the mid-cycle that ensures a conversion in the second meiotic division to a perfect metaphase 2. And this is what the agonist trigger does. So the agonist trigger is in fact superior to an HCG trigger because it is more physiological and it makes sure that you get both LH and FSH surges. The downside is that, of course, if there is abrupt luteolysis, you don't have a good functioning corpora lutea. The endometrial receptivity is not good. Patient usually menstruates within 3 or 4 days of the agonist trigger, and therefore you cannot do a fresh transfer. But as far as quality of embryos, conversion to metaphase 2s is concerned, the agonist is equally good, or according to me, better than HCG for giving you a full conversion. So of course, for poor responders, we prefer to use a dual trigger, that is a combination of HCG with a 0.2 of triptorelin. And as you can see here, live birth rates up from 14.5 to 27% when you use both the triggers and get the advantages of both a very strong LH peak and a good FSH surge to give you more number of metaphase 2s. Very important now, of course, we are in a times of individualization, and please, I'm sure most of the established IVF clinics are now only dealing 60% of cycles are patients who have failed IVF somewhere in the world. So we have to make sure that we give them the best. What are the roles for various supplements and add-ons, which I'll quickly take you through here. And you can see ubiquinol, of course, we have enough evidence now of classical study from 2015. You can see this is a young ovary, mouse ovary. This is an old menopausal mouse ovary. And this is the same second ovary after 15 weeks of coenzyme Q. You can see the amount of regeneration that it shows. And we have enough papers and evidence now, and I'm sure all of you are using it. The second most important, of course, is androgenization. Again, very important because with advancing maternal age, there is a reduction in intrafollicular androgen levels. A wonderful paper here. Of course, I always use transdermal testosterone, but this is 1 month of treatment and they call it andro IVF. 1 month of pre-treatment with transdermal androgel alternate days, oral letrozole 2.5 mg daily, and subcutaneous HCG 2500 IU. And all this is given for a month prior to stimulation. And what is the physiology of it? That increased testosterone gel will help to increase serum androgen levels. HCG will help to increase intrafollicular androgen levels. Letrozole will prevent aromatization to estrogen, and letrozole will increase intraovarian concentration of androgens by inhibiting aromatase activity. So they showed a greater than 5-fold increase in the number of follicles. Ancillation rates were very low and excellent clinical pregnancy rates in these poor responders. So you can see here with the andro IVF, the number of oocytes went up from 2 to almost 6 with good androgenization in the month prior to stimulation. So in clinical practice, I like to give ubiquinol resveratrol combination for 2 months, testosterone gel for 21 days. So it begins on day 6 of the previous cycle and she takes it for 21 days. And of course, vitamin D once a week before you jump into stimulation. Again, comparing the agonists and antagonists specifically for various Poseidon groups. Huge paper puts all your doubts to rest. Finally, you can see here, Poseidon group 3, live birth rate per transfer with the agonist up to 31% as compared to 17% with conventional antagonist. PPOS, again, for poor responders, physiologically, yes, it would be beneficial compared to long agonist because you don't get over suppression. But again, it can only be restricted to patients who are doing a freeze-all for any other reason. And this is a study which shows that you do not compromise embryo ploidy rates when you are doing PPOS, because we are always concerned that, oh, PPOS might cause aneuploidies in the embryos, there's premature exposure of progesterone, and so on. So although Polizos in 2024 showed that there was no such compromise, we have another study where when you specifically look at women above the age of 35, you need to be careful because the study showed that when you compare PPOS to antagonist, in this group, your euploidy rate per blastocyst drops from 27% to just 5.4%. So this is why individualization is so important. You know, as a knee-jerk reaction, tomorrow you go and tell your staff, oh, let's do PPOS for all. That's not the way it works. You need to make sure that you have enough evidence before you make any changes in your protocols. So why higher aneuploidies with PPOS in the elderly age group? Maybe because of these various reasons, local effects from supraphysiological progesterone, Synthetic progesterones are not the same as natural progesterone. In mice, they have shown that exposure of progesterone will reduce blastocyst formation and inhibit resumption of meiosis, and so on and so forth. So be careful with your above 35 age group. Under 35, maybe it should be the same. So this study said that especially above the age of 38, PPOS yields a euploidy rate which is 4 times lower than that of the antagonist protocol. Dual stimulation, it came with a bang, went with a whimper. I don't know, whatever you believe. But the fact is that we got it all wrong. And now there is a twist in the tail. As I told you earlier, when we did our original dual stimulation around the times of the pandemic, the first follicular phase stimulation ended with an agonist trigger. And as I told you, the luteal phase is very short. There is premature luteinization. The patient menstruates within 3 or 4 days. We were then starting another round of stimulation and labeling it as a luteal phase stimulation, forgetting the fact that she's menstruated, so she's back to day 2 of a follicular phase. So all we were doing is actually 2 consecutive follicular phase stimulations and giving it a fancy label of dual stimulation, FPS followed by LPS, and so on and so forth. We also had the problem that we could not do fresh transfers because we were doing so-called luteal phase stimulation, and we were getting more and more worried about macrosomia and PIH in HRT FET cycles. So this is the actual way that you should be doing a dual stimulation. You do the first stimulation in the luteal phase. So you can see day 21, you begin your stimulation, add your antagonist, give an agonist trigger, do your retrieval, let her menstruate. Day 2, you begin your conventional follicular phase stimulation. Again, add the antagonist. Give an HCG trigger this time, so that you can do a fresh embryo transfer using whichever set of embryos is of a better quality. So this is the actual way of doing dual stimulation, true luteal phase stimulation, which it should be done. Of course, this time don't jump into it. We are expecting the results of the largest study soon, probably, hopefully before ESHRE at Paris this year. And once we see some benefit in this, maybe we can employ it. And the benefit should be that success rates are higher than doing 2 follicular phase stimulation, not just getting more oocytes and embryos over one menstrual cycle and overburdening the patient with so many injections and double anesthesias within one menstrual cycle. So in the future, do I see any hope? Of course, we know that PRP has become a big fad, and again, it's a fantastic add-on for us. It's simple to do. This one study we have from Kakiroglu in 2022 showing improvement in antral follicle counts, higher number of mature oocytes, better number of blastocysts. But again, it's the young ones who do the best with the intra-ovarian PRP. So again, don't recommend intra-ovarian PRP to a 43-year-old with an AMH of 0.1 and no antral follicles, because it's not going to work. But if you have a 38-year-old with an AMH of 0.3 and you're seeing 1 or 2 antral follicles, maybe you can do an intra-ovarian PRP at the time that you do your first egg retrieval, so that you don't have to put her through another procedure again. What seems to be promising, of course, is to do a combination of OFA and intra-ovarian PRP. We know OFA means you do a laparoscopy, do a small biopsy, make small fragments of the ovary and reimplant them into a pocket just underneath the ovarian cortex. And at the same sitting, you could do 2 injections of intra-ovarian PRP on the anterior and posterior surfaces. And hopefully, this should give us better outcomes. I really feel strongly about laboratory aspects, because whenever you are dealing with a poor responder, there is a tendency, oh, she has only 2 sites, better do ICSI, don't take a chance with IVF. Let's do PGT. She's 38 years old, she has only 4 eggs. We must do PGT, that will help us to improve pregnancy rates. Or should we do oocyte activation with a calcium ionophore for all? So let's set the facts right that ICSI is not indicated. Please avoid unindicated ICSI. There are more than 30 publications on PubMed clearly showing number of oocytes and age of the woman should not be deciding factors for IVF versus ICSI. Oocyte activation, yes, it helps. So after you have done your ICSI, you can put the injected oocytes into a calcium ionophore activation medium for about 15 minutes and then into regular culture. And this will give you a 3 times higher chance of getting a top quality blastocyst. PGT, and this is the best paper that all of you need to go and read about, because it's been left, right, center being recommended for all these difficult categories of patients as if it's some magic which is going to happen and the patient is going to take home a live birth baby. So this paper by Alviji and a lot of other authors is about opening the black box of PGT, that despite your PGT, I'm sure all of you have seen that the patient still doesn't get pregnant. with a euploid embryo, or despite you're telling her that this will reduce the miscarriage risk, you again have an early miscarriage, although you had thumped your hands and told her that this is a euploid genetically tested embryo, so it will not end in a miscarriage. So what they did, they analyzed 1,600 items from 400 papers, took into consideration embryonic, maternal, paternal, clinical, and laboratory factors, and clearly showed that just by doing a euploid blastocyst transfer, you cannot compensate for advanced maternal age if primarily the embryo quality is not a double AA or a grade 1 and she has fragments, if she is obese, or if she's a case of recurrent implantation failure. And these are the four categories where we keep pushing PGT, thinking that it is going to improve outcomes. So please rethink, relook. This is the largest study. They have analyzed each and every published paper on PGT and clearly come to the conclusion that just by doing a euploid transfer, if the primary morphology of the embryo was not good, you are not going to get a viable live birth. So again, old is gold. What your eyes saw on day 2 or day 3, a cleavage stage embryo, very clean, super sized, same size blastomeres, no fragments. Yes, pregnancy is likely whether you do PGT or not, and so on. So you have to keep this in mind. And now there is, of course, a lot of papers coming after this as well, that we need to rethink the real position of PGT. And of course, before I take you on, this is a really interesting concept now of term stimulation, which clearly tries to mimic what we always learned about pregnancy. That just like we don't like a premature delivery to happen for our pregnant patients, maybe all these years we have been doing preterm stimulation. What do we mean preterm? That we stimulate and we trigger too early compared to a normal physiological menstrual cycle. So of course, as of now, these two cases are only two patients who have failed 2 IVF cycles because they did not produce a single good embryo. So please don't go and start doing it for all your Poseidons tomorrow. We still need a lot of work on to how to individualize this particular style of doing stimulation. And it's based on the fact that as age advances, baseline FSH increases, and age-associated ovarian fibrosis, collagen accumulation, and structural stiffening are factors that we probably don't take into account. So term stimulation extends stimulation to the physiological duration of the follicular phase. And what is the physiological duration? Just as you have 40 weeks of pregnancy, the normal physiological follicular phase is 17 days before the LH surge, as seen in most fertile women. And in this 17 days, you have to maintain FSH levels in predefined limits. So you can't overdose at 300 and 450 for all your patients. And currently, again, I repeat, it is only reserved for patients who have had at least 2 previous attempts of IVF, which failed due to either poor embryo quality or only retrieving aneuploid embryos. So simple. You can see here 42-year-old, BMI 30, AMH 1.13, 2 prior first cycle, she had only 150 XY. Second cycle, she had a 45 XY. The third one, where the duration of stimulation instead of 8 and 10 days was the full term 17 days. They got 7 metaphase 2s, 3 blastocysts, and finally got 1 normal 46XX embryo in this patient. So how is it done on a practical basis? You can see her baseline FSH here is at 9. So you set the target serum FSH between double, that would be around 17. So it has to be between 15 and 20. So if you put this as 9, double of 9 is 18. So you have to maintain her serum FSH between 15 and 20 throughout stimulation. So you can see here, it goes up to 23.2 on 6th day. Immediately the FSH dose is reduced from 300 to 225. Then again, you see here 17.2, which is fine. So you maintain 225, and then 14.75. So it has dropped below 15. So you just step up to 300. This way you take her the whole 17 days. Of course, it has to be a long agonist protocol. You cannot do this in an antagonist cycle. And follicles, as you would all imagine, would go to very large sizes of 24, 28, and so on. And this is how it was done and how they ended up getting a normal embryo. Similarly, a second patient, you can see here, duration of stimulation 13 days, 13 days, no embryo, just a poor quality day 3 embryo, no embryo at all. And then when you did a term stimulation, you had 5 blastocysts of top quality. Again, here you will see her baseline FSH was low at 2.8. So the target was to maintain between 5 and 10. You can see it was maintained 9.5, 9.6, 5.8. So you can see the doses reduced from 300 to 150 to just maintain her FSH between that 5 and 10 target. There were even days where no FSH was given. You can see here 0 and 0. So coasting is also okay. compulsorily you have to complete 17 days and not even look at follicular sizes. So this was the new kind of concept that we have, and I'm sure all of you are aware that there are new papers coming in that we need to trigger or delay the triggers for some categories of patients, especially the Poseidon 3s and 4s. And what about your worry about luteinization of follicles? Of course, they give diclofenac vaginally 50 milligram twice daily was given in this study to make sure that you do not have any premature luteinization of the follicles. So in some cases of diminished ovarian reserve, extending the follicular phase to term gives us an opportunity to achieve pregnancy, especially in patients with very poor egg quality. Average daily dose was much lower, so it was not higher. And again, remember that the adverse effects of FSH are mediated not by the total amount that you put in into a cycle, but by its daily peak concentration, which should be just about double of the baseline serum FSH. Of course, moving on to PCOs, we don't really have too much new things coming here, except one new protocol, which I'd like to share. 2 months of pre-treatment with myoinositol, of course, we like to do. Again, OC pill pre-treatment. You can see this paper here that people who can start IVF following a spontaneous menses had a much higher live birth rate compared to those who were put on OC pills in PCO prior to their IVF cycles, with a so-called intention to regularize a cycle and get a good menses. Numerous papers clearly showing slower follicular growth, and I showed you this earlier too, because then when you start with just rec FSH, you will not have a normal follicular phase, lower E2 levels, lower ongoing pregnancy rates, and most importantly, higher miscarriage rates in the OC pill pretreatment group. And this is because most of these PCOs will need the agonist trigger, and if you have given prolonged OC pill pretreatment, her LH is suppressed too much. You can see the lower the LH at the start of stimulation, the higher the incidence of a suboptimal response. That means 50% of patients, you may have 40 follicles and get only 20 oocytes. You may have 20 oocytes and get only 5 M2s. So please do not use OC pill pretreatment for PCO patients. This new study, again, as I told you, the Chinese study, where they give a 7-day washout period and then begin the FSH, and they found that you can see here that high LH levels on the day of gonadotropin initiation did not have a negative impact on embryo quality. So please stop checking LH levels on day 2 for PCO patients and then thinking over baseline LH is 3 times higher, 2 times higher than the FSH. So I must give her suppression with OC pill. You do not need to do any such thing. And you can see here, this was a large study, more than 1,000 embryos in both the groups. And they clearly showed that high LH levels on the start of stimulation in a PCO patient does not have any negative impact, and you do not need to give OC pill pre-treatments. How about reducing miscarriage rates? Of course, all of you have heard this again and again, the Megaset HR trial, where they compared HP-HMG with HCG-driven LH activity versus REC-FSH, and they found a reduction in early pregnancy losses with HP-HMG as compared to REC-FSH. When they looked at frozen embryo transfer outcomes, again, they found a reduction, almost half the early pregnancy loss as compared to REC-FSH alone. And when you look at cumulative live birth rates, although they were the same over a 6-month period, the same live birth rates were achieved with 43 fewer transfers in the HP-HMG group using 65 fewer euploid genetically tested embryos. So time to pregnancy is faster. Despite euploid embryos in both the groups, yet the miscarriage rates were lower in the HP-HMG group. And what are the reasons for this? Maybe embryo quality, we know HCG has a tendency to accumulate as compared to native LH, which has a very short half-life. So the higher the HCG level on day 6 of stimulation, the greater is the proportion of top quality embryos, and therefore lower miscarriages that you will have in your high responder and PCOS group. And this is the protocol I want to share with you before I wind up for today. And this is a new concept, again, about delaying the trigger in a PCO patient for a better outcome. So please pay attention here. It's very simple to do. FSH 150 from day 2, HMG 150 from day 7, antagonists to be added not at 14 mm, but when the leading follicle reaches 18 mm, agonist trigger when the largest follicle is 24 and not 17, 18 as we normally do. If her E2 level on the day of trigger is 4,000 to 5,000, you give her 1 tablet of letrozole before giving the trigger. And if her E2 level is 8,000, 10,000, anything more than 5,000, you give her 2 tablets of letrozole before the trigger is administered. And what did they find? This group A was the classic agonist protocol. Group B, antagonist with HCG trigger. Group C is what all of us do for our PCOS patients, antagonist with the agonist trigger. And group 4 was this new modified protocol of FSH followed by HMG followed by late start antagonist and letrozole on the day of trigger, and late trigger at 24-26 mm rather than 18 or 19. And they showed a reduction in miscarriage rates. Finally, we have something which reduces miscarriage rates. You can see just 19%, and cumulative live birth rate 30, 38, 37 up to 57.4%. So this was presented at ESHRE this year, and we were fortunate to hear him even at I think IFFS at Ahmedabad. He was there and presented the same paper. There was a lot of interaction, and it sounds like a very promising way of reducing miscarriage rates in PCO patients. What about PPOS? In PCOS, again, you can see clinical pregnancy rates by Chen's paper here. We thought it only reduces number of injections. We thought nothing else changes when you compare PPOS to the antagonist in PCO patients. But Chen actually showed that even the embryos are probably better, and you have higher clinical pregnancy rate, 62%, as against 47% with the antagonist. So of course, when they talk about Poseidon Group 4, remember they have further fine-tuned the PPOS that you don't have to give it from the beginning of stimulation. You can, just like we had antagonists at 14 millimeters, so also PPOS can be added at 14 millimeters. We started off with medroxyprogesterone 10. There were papers then brought it down to 2.5. Then they said dufastone is equally effective, 30 milligrams. Then they said 20 milligram is enough. And now most recently, we have a paper from Polyzosis group that just 200 milligram of oral micronized vaginal progesterone, one capsule a day, is enough to suppress the premature LH surge. So not even vaginal administration, just orally, one capsule of your normal micronized MVP, which we give to all our patients. So this was the paper. Sorry, I already mentioned it in advance. So whether you use MPA, dydrogesterone, 10 or 4 mg of MPA, or even just 200 mg of micronized progesterone orally is enough for these patients. Finally, of course, random start. The reason I put this, a lot of times a donor comes to us and we say, okay, you come back on day 2, and sometimes she doesn't come back for whatever reasons. So can you directly start ovarian stimulation without compromising the outcome? So this was a study done by Rafael in 2024, where the stimulation is started as soon as the donor lands up at your clinic, and they compared the various groups: conventional group where you start on day 1, 2, or 3; random start when you start any day after day 4. Here they categorize day 4 to 14 and about day 14, and they found that there were no variations in the pregnancy rates in the recipients. Of course, there is a longer duration of stimulation, higher FSH consumption, but otherwise there is no general difference and can be easily recommended for oocyte donation programs. So finally, to end, most of you come across failed IVF patients, and we know what Einstein said. And the reason I put the same thing 3 times is just to drive home the point that if you do the same protocol with the same doses, with the same blastocysts, with the same HRT, FET, cycle after cycle, you are not going to get a different outcome. So please change everything. You have so many options now between agonist, antagonist, PPOS, and the latest term stimulation, using REC-FSH or HMG, using HCG, dual trigger or agonist trigger. Don't be fixated on blastocysts and PGT. Remember the days of your day 3 when you still had the same 40% pregnancy rates. Remember the days of your fresh transfer when you still had 40% pregnancy rates. And this beautiful new study now where they've compared doing one fresh followed by a frozen compared to doing frozen followed by frozen. So all of us, had shifted to this freeze all policy some years ago, thinking it is superior. If you do a fresh followed by a frozen, your cumulative live birth rate is much higher than if you do FET followed by FET with the same HRT preparation. So again, never repeat the same thing. And probably in a fresh transfer, there are a lot of other implantation factors, a lot of other hormones, and besides just estrogen, progesterone, which are probably giving you higher pregnancy rates in fresh transfers in some categories of patients. Luteal phase stimulation again should be individualized. For example, above the age of 35, vaginal micronized progesterone is not very well absorbed. So try to prefer a little injectable for this group. Now, how many of you knew that? And this is the meaning of individualization. Judicious use of supplements, and please, please, please weigh the risks and benefits of all your add-ons before you burden the patient with excessive expenditure. So thank you once again. Thank you, Dr. Latika. She's been in touch with me throughout. And of course, everybody on the panel, all the delegates. I'm sure I overshot the time as usual, but I hope all of you enjoyed this session. Thank you so much.
Dr. Jatin, it has been amazing. It has really been amazing. And normally 15 to 20 minutes is something which you normally get. But over here, you have been there for about 1.5 hours, giving
Grateful for
everybody.
that.
And it's amazing. And in fact, it's such a beautiful, I would say, program where you have Dr. Latika, always so elegant, Dr. Ori, always smiling, Dr. Rakhi, your energy is unparalleled. And Dr. Shivani, of course, you are the glamour, but you know, the superstar over here, of course, is you, Dr. Jatin. And it's amazing. Thank you very much for being here. I just was wanting to point out one small thing which I always have felt, apart from the clarity which you have given. And in fact, if you ask me, you have really made something so complicated so simple. I would say, you know, I always believe in one thing. In fact, Einstein said this very beautifully. He said, a very intelligent man can simplify a complicated matter, but you always find people who complicate simple matters. So I think this has been amazing and very nice. There was only one thing which ultimately the aim of any ovulation induction is to optimize the results and get the best possible results. And with every ovulation induction which we do, I have always particularly felt that the male sperm also needs to be optimized along with the egg.
Right.
So looking at the man optimizing his egg, his sperm, optimizing the egg just as you have rightly shown, and in the end, optimizing the laboratory for the best possible result is what we all aim for. And thank you very much, Dr. Jatin. Thank you, everybody, for inviting me over here. But most importantly, I've loved the presentation of yours, which somehow was 1.5 hours, which probably could have been longer if time permitted.
Right.
And thank you, everybody, for this beautiful
It
presentation.
was indeed a mesmerizing presentation, and you have not left any stone untouched with the latest things, and feel like listening to it again and again so that we get the feel of it.
We have the recording. You can listen it again
Yeah,
and
I
again.
would love to listen to it because it was a marvelous, mesmerizing presentation which had everything which is included. And if a person mugs up any person, he would understand what is infertility and what is IVF and how it has to be done. And the sensitization is quite a good over there.
Thank you, Dr. Jatin. Really a masterclass for all of us today. I wanted to mention about that with term stimulation, you also mentioned higher, but you did not have a slide on higher, the highly individualized egg retrieval, where actually you are giving trigger at 16 millimeters instead of later. Is that correct? Is that the higher that you mentioned?
No, I didn't
आपकी
mention
स्लाइड है
anything.
ना टर्म स्टिमुलेशन, उसके साथ एक HIER हायर करके प्रोटोकॉल भी लिखा हुआ था. तो हायर इज दैट हाईली इंडिविजुअलाइज जिसमें पुअर रिस्पॉन्डर्स को बिकॉज ऑफ प्रीमेच्योर लुटिनाइजेशन द ट्रिगर इज गिवन अर्लियर.
No, it was not part of this study.
It was not part, but it was in your slide. I saw that in the term stimulation.
It
If
is
you
the
go back
same
and look
group.
at your slides, you will find that.
So I'll just check it out. Maybe that was in the previous 2 cycles they might have done, na? Maybe something like that. Because I showed
हाँ,
first
तो
cycle,
आपने
second cycle.
हायर मेंशन किया, so I thought
I'll
maybe you
just
will
check. I'll just
explain
check.
कि instead of late trigger एक concept जल्दी trigger का भी है, but somehow that was not. तो आप अपनी term stimulation वाली जो first slide
I'll
है
check.
उसमें
I'll check.
ये higher लिखा है.
I'll check it. I'll check it.
So thank you so much for masterclass. Really, I think I took out time. I made everybody wait because I need 1.5 hours with Dr. Jatin Shah to listen. Thank you.
Everybody looked like this, na? Because to hear Dr. Jatisha is a treat, really.
Really, Dr. Latika and Dr. Neelam, thank you for
It
this
is
treat
really
today.
a treat to listen to him. Always, wherever he is giving a lecture, it should not be missed anywhere.
I'm sure it is packed and overfull.
Yeah.
Yeah. So thank you, Dr. Jatin, for a
Dr.
fantastic,
Anu,
fantastic
Dr. Anu,
lecture.
Dr. Anu
Dr.
has
Anu,
to, Dr. Anu,
Yes, ma'am.
I think she is
Jatin
there.
sir,
Yeah.
thank you. Thanks a ton for your wonderful talk. Basically, I make it a point and I'll never miss any of your lectures, sir. Thank you, sir.
Thank you. Thank you so much. Yeah,
thank
I
you,
Sure,
Dr.
you
Shivani, I
start.
Jatin.
checked that. Shivani, I checked what you
Thank you,
said.
Dr.
So this
Jatin. It was really, sorry.
this paper described both. So they compared higher to term simulation. Both of
Okay.
them. Yeah. That
Okay.
is, I just checked
So
the slide.
higher
You
is
said was
16
correct.
पे trigger
Yeah. So
and
higher
term
is already
stimulation is
known.
24 पे trigger.
Yeah. So this paper is going against that concept. So that is why they have
Right.
taken it as higher and term stimulation as options, for individualizing treatment for poor responders. That way.
Correct. Correct.
Thank you, Dr.
Thank you.
Jatin. It was really thought-provoking for all of us, and it was really marvelous. And you told many new concepts also. I just wanted to ask that, have you ever thought of giving oral antagonist, which has come?
I
as-
think then if you want to give oral, then PPOS is better anyway, and the cost
Okay.
doesn't justify it. I think I'm not sure what is the cost right now, Villa colleagues. Any idea?
Uh, it is
2000.
around 100.
Yes,
Yeah.
I think
150.
one tablet is 300 rupees or something, and it is the 150 tablet, but you have to give 200 BD, and it is not licensed by FDA for
Right.
IVF, so it is an
Correct.
off-label use. So
Yeah.
in this legal era, you are taking a very big risk. So it
Right.
is absolutely, as Dr. Jatin said, not worth it.
No, not
They
worth
have
it. It's
told
not
about
cost effective. We don't have
endometriosis
any
as
papers.
adenomyosis.
We don't have any papers on it as of now. None of us have used it. So all these companies are after us to give a lecture. Give a lecture. I said strictly no, nothing doing till I don't use, till I don't see published literature, till I don't hear about essay or SRM. I am not going to give theoretical talks on this. So I said right now you restrict to your
They are also
endometriosis.
not recommended
Yeah.
for IVF. They
No,
are
it's not.
recommended
It's
for,
not.
yeah,
No, they are
adenomyosis.
trying. They are trying to push
They are
into.
trying their level best to put it for IVF, but
They
it is
made me.
allowed
They
for
made me
Yes, they
cut a
are
cake
trying.
also.
They have offered me also for egg donors
Yeah.
200 BD ka dose, but of course, as Dr. Jatin said, मतलब पहले ही क्या कम है hammer on our head, so we don't want to take
अरे
risks.
PPOS can be given na egg donor में one tablet meprate. What does it cost? Nothing. Why would you want
Yeah,
to use so much?
that's true.
Dr. Jatin,
Exactly.
are you taking the help of AI in embryo selection in your day-to-day practice, in IVF practice?
No, I use AI to make my presentations as of now, and that's where it stops.
Amazing slides.
Because now
Amazing
PowerPoint has
slides.
a nice new feature. You must have come across it. There is a
Yeah,
new
yeah, yeah.
co-pilot.
So
It's a feature
your
called co-pilot.
your eyes
What,
and
what,
brain is the actual
what
AI.
do we do for embryo selection? Your eyes, you trust on your eyes or something else?
Since last 32 years, I make embryo plates for each and every patient in the morning.
Okay,
Oh, wow.
then you are
Wow.
fresh.
Incredible. Incredible.
Only last 10 years, my daughter's taken over that part. But yet I insist on seeing each and every embryo. And I think most of you know, I load the embryos and take the catheter. I don't let the embryo.
Really
So that is
amazing
my
work.
second glance. So that is the second time I see the embryos when I load them also. So it's just a habit, it's a because when we started 32 years ago, we didn't have embryologists. We were only doing everything. So that habit has stuck with me somehow. So that's what I tell all these AI people, that somebody who has seen millions of embryos, AI can't replace so easily. Of course, AI will have its own advantages, plus points.
Yeah.
Obviously. They'll go into three-dimensional and all kinds of things which the eye cannot see. But let's see. I think it's about 10 years away. I am waiting for AI to help us decide the starting dose and to decide the day of triggering. These two things, I think, if they give us as clinicians, forget the laboratory aspects, will really be useful because most cycles go wrong on this only. The starting dose is not right, and 80% go wrong because the triggering day is not correct. Either we push it one day, or Sunday nahi karna hai, Monday karna hai, or let's do early, late. That is where we compromise some cycles. So if we have very good AI tools where you just feed in the follicular sizes, the blood flow, and the E2 level, and you get okay trigger tomorrow, then I think it will take away a lot of.
True. Yes.
So thank you so much, all the dignitaries.
Also, study of Boston IVF, where they had funded for the AI machine running. And they wanted it to be known, as you were suggesting, that what would be the dosage which is required and when the day of the trigger. With the 80,000 IVF cycles also, the data what was provided, I was part of that.
Yeah, it's
Where
not easy. It's not easy.
I was on the board by the AI people, but it did not materialize
Because
to
we have
that.
too many variables. Now you can't compare an
There
agonist
are
cycle with
so
an
many
antagonist
variables, and
cycle.
it was very difficult
Somebody
to.
is using urinary FSH, somebody is using rec FSH,
Yes,
HMG, everybody is using different combinations from day 7, day 2, day 3. How will you come to an algorithm? Na?
yeah, there
Unless you
was
do
very difficult to do
you
it.
have to do 1,000 cycles with the same thing. Then you can
Everything
do it.
similar, then only because they had given the whole data this way, and it was very difficult to do it.
That's why I told you 10 years away. It's not going to come
Yeah.
with.
Dr. Jatin, you do fresh transfers also in your
Yes, yes. Lots,
IVF
lots.
practice.
Yeah, yeah. We do a lot of agonist cycles. We do a lot of fresh transfers. We go by simple clinical criteria. Less than 13 oocytes, triple line endometrium, progesterone between zero point 0.5 and 1.5. Fresh and frozen is same outcome. There is no justification in, doing vitrification and freeze-all. So all this we need to change our, because I have a lot of other talks on freeze-all and why not to do freeze-all and all these things. Because, science keeps changing, but somehow we don't change so fast. So first of all,
Yes.
you should not make a sudden change. And if you have changed, then you should always go back to what was working better for you. So fresh transfers definitely huge role to play. A lot of patients after 2-3 failed cycles, suppose they have come to a clinic, the only change I make is, okay, let's try a fresh cycle, because all the previous clinics have done FETs. And the minute you do fresh, something works. If all the previous have done blastosis, I say let's do simple day 3 and it works. So you must
Yes.
keep getting very interactive with things.
Jatin sir, one question I wanted to ask. Sir, are you doing fresh transfers in patients in whom you have given dual trigger?
Yeah, we can do, no problem. But we try to avoid, we just give the HCG trigger if it's pre-planned that she's going for a fresh transfer.
Dr. Jatin, for in PPOS, so for antagonist, as we give the last dose on the day of HCG or day of
Same.
trigger. So
Even same here.
PPOS, can't we extend for one day more because
Why
it
would you
takes
want to give
one?
one more?
Huh?
No,
No.
why do you want to give one more? No, you are supposed to give on the same task.
To might miss LH
No.
that
They
might
will
occur.
not have. They will not have any LH.
So now the webinar is over now. Dr. Jatin, thank you so much for sparing your valuable time and coming to us to
Thank
give
you
a
so much.
wonderful talk.
Thank you, everybody.
And
Thank you.
Dr. Usha Sharma being the chief guest and sparing her valuable time. All the chairpersons, Dr. Shivani, Dr. Jindal, Dr. Anu, Dr. Rakhi. Thank you so much, all the delegates and all
Thank
the
you very
dignitaries.
much,
Thank you.
all
Thank
of you. Thank you very much. We really had a very nice evening today with Dr. Jatin and all of
Thank you.
you.
Thank you.
Thank
The best part was
So
no
much.
timer, unlike our
Yeah,
conference,
Yes.
which is when I am at my best flow, when there's nobody
Yeah.
looking at me and ringing the bell and
we
telling me
remember
to.
Isar Lucknow hall was full, sir. The people were not getting the chair to sit,
15
and
minutes
it was
before the
full.
lecture.
Yeah. We came 15 minutes before the lecture to occupy the chair.
It happens every
Thank you
year
so
now. I
much.
have no choice. Somehow
Yes.
I always end up getting the smallest hall.
But they know, na, in a small hall also you get
Audience.
so
It
many
will be
audience.
overflowing.
Yeah.
Keep going.
Thank,
Yes.
so
Okay,
thank you
thank you
so
so
much.
much. Thank you.
Thank
Smallest hall is their loss, not of yours.
Yeah.
Are
Organizers
always
loss.
benefited, sir.
Actually
Everybody
true.
would want to listen to you because the crux, how it is given, it is superb.
Thank you.
You tell the practical things also, na?
Yeah, practical and how it has to be done. It is not just the theoretical lecture, it is just the practicality, how it has to be approached and how much dosage and how, where the pitfalls are there. We need to learn all that basically. Everybody is coming for the lecture for that reason only, to hear. Thank you.
Okay.
Thank you. Thank
Great.
you.
Okay, bye-bye.
Thank you. Thank you,
Thank you.
sir.
Bye-bye.
Latika, thank you. It was a lovely lecture.
मैंने तो इसलिए रखा डॉक्टर जतिन का मुझे मालूम है
नहीं,
कि
उनका
सबको
तो
बहुत अच्छा लगेगा
obviously it would be
Thank you.
definitely.
It has been a great and good time given to serve, which actually is needed.
Yeah.
yeah
Hmm.
that's why we didn't keep another thing only his
Yeah.
lecture
Yeah.
Very true.
Thank you so much, Manu. Thank you.
okay
Thank you.
okay bye bye
Bye.
Good night.